Hi, I'm Seth Wolk. I'm the System Chief Medical Officer for Spectrum Health. I'm also the President of Spectrum Health Medical Group. Today I'm here with Dr. Brian Lane. Brian is the Chief of Urology at Spectrum Health. Thanks for coming in, Brian.
Thanks for having me.
Brian, the field of urology has certainly changed since when I trained as a general surgeon many decades ago, and especially the treatment of prostate cancer. Can you tell me a little bit about what's going on in the treatment of prostate cancer? What are the trends?
I think a lot has changed even since I went through my training, and I haven't been in practice as long as you have been, but there's really been some big changes. First of all, we've done a lot to focus on specifying what treatment individual patients receive, and that's at both ends of the spectrum. We want to avoid overtreatment of patients who have a prostate cancer that may not end up shortening their life and where the treatments may have significant quality of life impact. On the other side, we want to make sure that we're providing multidisciplinary care and multimodality care for those patients with more advanced disease. And so we're increasing the use of treatments for patients at more advanced stages of disease.
So Brian, we're sitting here today in Lemon-Holton Cancer Center, and I know you run and participate in multi-specialty clinics, MSTs, I think you call them. What are they and what value do they provide?
I think the value of the multi-specialty team is both to the individual patient and to the institution. For the patient, they get the opportunity in one setting to hear multiple opinions from experts in different disciplines. And so for prostate cancer, when surgery and radiation are often similarly good options, or certainly both need to be considered, it's nice for the patient and their loved ones to get input from both of the specialists in those areas at the same time. It also gives us as a community the opportunity to be all together in one place so that we can review what we've learned and hear the patient's preferences and see how those apply for their care.
Tell us about outcomes and what you're doing.
So my senior partner, Dick Konoski, had started recording all of our outcomes and doing so in partnership with some other academic institutions with a program called Capture. And with that, our patients were submitting surveys both before treatment and then annually after treatment, so we can follow the 5, 10-year or further outcomes on these quality of life questionnaires that are very extensive and provide a lot of detailed information. Since then, we've also participated with something called MUSIC, which is the Michigan Urologic Surgery Improvement Collaborative, and that similarly has provided specific outcomes in surgery patients that the patient themselves are filling out before surgery and then at several time points after. So having these type of hard endpoints, these data sets, really helps us to see how we're doing comparatively with other institutions across the country or across the state.
At Spectrum, my understanding is we have some fairly sophisticated technology that can help with the actual genomic analysis of tumors to help individualize treatment. What do we have here?
Spectrum has, at the Advanced Technology Lab, the ATL, has some very robust technology to perform next generation sequencing of cancers, to perform basically sequencing for mutations or for amplifications in a whole host of genes that when they go awry can amp up the cancer.
And why does that make a difference to a patient?
There are two ways that molecular information can be helpful for patients. The first is just to provide information about their likely prognosis. So is their cancer more likely to come back? But the more important way is prediction. And so some of these markers provide predictive ability where if you have a mutation in a specific gene, then we can use targeted therapy that is used for tumors that have that specific gene pathway altered. And so you may have a very advanced prostate cancer that's gone through multiple lines of prior therapy. Now we see a gene that's unusual and we can use a different line of chemotherapy for you.
So Brian, how prostate cancer is diagnosed is important. What's new in the diagnosis of prostate cancer?
There's a lot that's new, and much of it is still controversial, some of which is not fully reimbursed at present by insurance companies. I anticipate we're going to see some changes in the next few years. They all relate to the fact that our standard methods for diagnosing prostate cancer, PSA, the blood test, and prostate biopsy, done in a systematic fashion with ultrasound guidance, have done fine, but the newer technologies suggest that we could do better.
So what are some of these new technologies?
So one of them is called a PCA3. It's a urine-based test that shows, again, a more likelihood of having cancer when it's elevated. There are some molecular markers, a temporous ERG fusion protein, and there are several companies that make these tests now that combine the multi-marker panels.
How about in terms of how a biopsy is actually performed?
So the newest method to do prostate biopsy is to perform a fusion of the prostate MRI images with our standard ultrasound. And so in real time, the ultrasound images are overlaid with the MRI images so that we can target biopsies into the areas identified on MRI. So in addition to the systematic biopsies, we can perform targeted biopsies. In our experience with patients with prostate cancer who are on active surveillance, actually 40% of them have higher grade cancers that were identified by this UroNav machine. And so that enables us to figure out who are the patients on active surveillance who might benefit from treatment, and to steer those who are on active surveillance appropriately more confidently on that road, avoiding additional biopsies or treatment.
Brian, when you and a patient decide that surgical removal of the prostate is the best treatment, how is that done today?
So the vast majority of prostatectomies in this country are now done robotically. It's something that's now got more than a decade of experience, and it's really moved from the era of experimental to really the standard of care. I think some of the advantages to it are the visibility that we obtain with the robot, with the magnified vision. It also has really, to me, been an important development because surgeons are better able to learn from one another by watching each other's videos, by discussing the techniques that they're observing, by establishing kind of a community standard of technique and appropriate and excellent technique. This was really challenging back in the day of open prostatectomy, when it was even challenging for the surgical assistant to see past the surgeon's head as to what was going on. So I think that truly, beyond the fact that it's excellent technology, is something that's really led us forward in the field.
Well, I'd like to thank you, Brian, for spending time with me today, sharing what's really going on in the urology program here, what's going on in Lemon-Holton Cancer Center. It's amazing. The community has a lot to be thankful for that you're here leading this program. Thank you.
Thanks for having me.